All right, everyone. So welcome to another conference on the immunowebinar series. Today, we are pleased to have Dr. Jamille Dombrowski as our speaker. Jamille has a bachelor's degrees from the Federal University of Acre and a PhD in science from here, actually, the Institute of Biomedical Science, University of São Paulo. During her PhD, Jamille developed an internship at the Centers of Disease Control and Prevention, the CDC, and also she had another experience abroad at the London School of Hygiene and Tropical Medicine in 2018. Currently, she's postdoc fellow at the Biomedical Institute here, ICB-USP, but she's located now in London. Her interest topics relate to parasitology, immunology, epidemiology, and the maternal and child health areas, where she's been develop a really cool work. Jamille and Professor Claudio Marinho group have mapped and characterized areas with high levels of malaria during pregnancy, for the last years in the north region of Brazil. And this work has been published in very important papers. One of them is more recently the Lancet Regional Health Americas. And at this moment, as I just mentioned, Jamille is concluding part of the postdoc in London, and she will talk more about that today for us. So, Jamille, thank you so much for accepting our invitation.
Thank you. Can I share my screen?
Yeah, yes, you can start sharing your screen, please. Thank you.
Did you see it?
Yes, yes. Excellent.
Okay. Hello, everyone. Good afternoon. First of all, thank you for coming, and thank you, Professor Gustavo, Luisa, and all the organizers for the invitation. As mentioned, I'm a postdoc in Professor Claudio Marinho's lab, and Professor Claudio has 2 lines of research in the lab. One focus on the immunoparasitology of the disease in murine models, studying innate immune response. And the second research line of the lab that I'm leading studies malaria in pregnancy in humans. And it's about this part with a focus on the epidemiological and clinical aspects that I would like to talk about today and present our latest results. So, similar to the last wonderful seminar last week by Professor Ana Cássia, I'd like to start by highlighting the numbers of malaria. So unfortunately, malaria remains a major public health problem, mainly in areas at risk of transmission. We are concentrated in tropical and subtropical regions. And according to the latest malaria report, approximately 241 million cases were reported worldwide, with over 600,000 deaths in 2020, with 92% of these deaths occurring in the sub-Saharan Africa region. Among the Plasmodium species that infect humans, there are 2 main ones: Plasmodium falciparum, where infections are concentrated on the Africa continent, and vivax, Plasmodium vivax, which is the most prevalent species in the Southeast Asia and in Latin America. In Brazil, about 99% of malaria cases occur in Amazon region, and according to the latest data, more than 140,000 cases were reported in 2020. So it's important to point out that it's estimated that more than 125 million pregnant women live in malaria endemic regions, and together with their fetus form an important population at risk for the most serious effects of the disease. And these two populations are at risk for infection, but for different reasons. So children under 5 years old, due to the immune system not being fully developed, and pregnant women due to a combination of factors involving hormonal regulation, immunological alteration, and accumulation of parasites in the placental tissue. So this is because the placenta is an important organ for the multiplication of the parasites. So the process is complex, but briefly, Plasmodium falciparum has the unique ability to sit adhesion due to the expression on the surface of the erythrocytes of a protein called PFMP1 that adheres to the placental tissue through the chondroitin sulfate A receptor, the CSA, present in large amounts in the placenta. Primigravidi are especially more susceptible to sequestering infected erythrocytes, as during pregnancy, women develop antibodies against this parasite protein that can block its binding to tissue to possibly be destroyed in the spleen, so reducing the severity of the disease in subsequent pregnancies. So the increased inflammatory response that occurs in placenta malaria is one of the main causes of adverse pregnancy outcomes. And what are these consequences? So for the pregnant women, anemia, abortion, other complications such as hyperglycemia, hypertension, and even maternal death. For the fetus, intrauterine growth restriction, fetal anemia, and congenital infection. And for the newborn, premature delivery, low birth weight, stillbirth, so many serious consequences. And it's observed that the severity of the disease also differs according to the epidemiology of the region. So, in other words, in regions of high transmission, where pregnant women are more exposed to malaria, it's common to observe the accumulation of the parasites in the placenta, altering its integrity, and this can interfere with maternal-fetal exchanges, reducing the transport of oxygen and nutrients, causing abortion, low birth weight, premature delivery, thus causing risks to infants. And in parallel, the pregnant women may have anemia, causing maternal risk. So, however, in regions of low transmission, where the pregnant women have low acquired immunity, these effects are more serious, increasing maternal and child risk. Oh, okay, I'm so sorry. I know this is the lunchtime in Brazil, but this is my precious. So to understanding more about placenta malaria, it's very important. So it's known that it's a transitory organ, but with high relevance as a functional center of maternal fetal system. So it is responsible for the metabolic, endocrine, immunological, and nutrition functions, in addition to serving as protection for the fetus. So this organ has a maternal phase with the placental cotyledons and a fetal phase where covered by the chorionic plate where the umbilical cord is inserted. So in these cotyledons, that the fetal villi and the intervillous space are found, and it is in this space that maternal blood circulates and transfers between mother and baby occur. So if we make a histological section in this region of the villi and visualize it under a microscope, we can better observe these structures. So here we have a normal placenta, so with all structures preserved and without any lesions. So we can observe the intervillous space where maternal blood circulates, the chorionic villi with fetal vessels inside, and the layer of cells called syncytial trophoblast. Extremely important because it doesn't let the mother's blood mix with the fetal blood, protecting the baby from many diseases. And when a woman is infected by Plasmodium, what we can see in the placenta is this. So a complete disorganization of the tissue. This is an example of placental malaria by falciparum, so totally different from the previous image. We can observe areas with necrosis, fibrin caused by coagulation, presence of syncytial nuclear aggregates, and an intense inflammatory infiltrated formed mainly by monocyte cells. So all these changes and this inflammatory environment make it difficult and even block maternal fetal exchange, leading to the consequences I mentioned before. Okay, and let's talk a little bit more about these changes in placental tissue. So first, microscopically. So here we have the placenta of a pregnant woman who didn't have malaria. And here, the placenta of a pregnant woman who had placenta malaria. So we can observe the presence of meconium, this green in the umbilical cord, which is the baby's first stool, but when it occurred before or during delivery, it's a sign of fetal distress. We also observe these whitish areas of calcification and tissue necrosis. So it turns white because there is no blood circulation. A placenta that has clearly had its function impaired. And looking at the microscopic changes in placenta, what we can observe. So we have the syncytial nuclear aggregate. It's a common alteration in pregnancy, but in placenta malaria, there is a significant increase in the number of these aggregates that are formed by the apoptotic nuclei of the syncytial trophoblast. And this increase is associated with placental disorder such as hypoxia. Another lesion observed is fibrin, these fibrin deposits, which are caused by blood coagulation or degenerative processes. So this is a lesion with an important biological risk as it prevents the exchange of gases and nutrients between the mother and the fetus. So, in addition, it also favors the appearance of areas with fibrin node necrosis, which is this next lesion. So, similar to fibrin deposits, makes exchange between mother and baby difficult. So, these two lesions are primarily responsible for intrauterine growth restriction and consequent low birth weight. The next is inflammatory infiltrate, so a direct consequence of the presence of the parasites in the placental tissue. So it is the increase in mononuclear cells, mainly monocytes and leukocytes in the intervillous space. The accumulation of these cells generates an intense inflammatory process with the production of cytokines and chemokines and the consequent recruitment of additional inflammatory cells. So this whole process is also directly linked to adverse pregnancy outcomes. And finally, we can also observe parasite and hemozoin, which may be circulating or adhere to the tissue in case of falciparum infections. So, although the above lesions, changes are frequently seen in placenta malaria, it's only with the presence of infected erythrocytes or hemozoin we can characterize placental malaria. So thus, it's this presence of the parasite and or hemozoin in the placenta that stimulates the recruitment of inflammatory cells. So through these two parameters, it's possible we classify placental malaria as negative, absence of both, active, acute, presence of infected erythrocytes circulating, and hemozoin in inflammatory cells, such as monocytes, active chronic, so when it's still possible to identify infected erythrocytes and hemozoin, but both in inflammatory cells or adhere in the tissue or fibrin, and past placenta malaria, whether it's only hemozoin in the tissue. So far, it has been a brief contextualization about malaria in pregnancy, placenta malaria, just to understand the context. So it's important to note that much of this knowledge comes from studies carried out in areas of high transmission, such as Africa, where falciparum is the most prevalent species. And in Latin America and Brazil, how are we going? So, fortunately, the number of studies on gestational malaria, placenta malaria, has grown a lot in all endemic regions, such as Brazil, Venezuela, Colombia, and others. So a lot of great work. And talking about Brazil, I'm going to show you our latest work and results. So starting with this paper that we published this year. So this manuscript arose from the need to understand the distribution of gestational malaria across the country and how the dynamics of cases has been over the years. So as I said, the number of articles are growing, which is great, but from an epidemiological point of view, it's difficult to extrapolate certain estimates. So as the studies were carried out in specific areas or regions. So we evaluated all autochthonous cases of malaria in pregnancy over a period of 15 years, so from 2004 to 2018. So we can see in this graph that despite the increase here in the final years, there has been an important decrease in the numbers of reported cases. This can also be seen on maps. So in 2004, the disease was well dispersed in throughout the legal Amazon region. And in 2018, we observed that cases began to concentrate in specific regions on the Amazon region. And through special temporal statistics, so an incredible collaboration we did with a group from the Faculty of Public Health, we aimed to, we identify important disease hotspots. So here in Pará, we divide vivax and falciparum infections, and we identify these hotspots in the region. So here in Pará, Amazonas, and in Acre State for both species. So here the Juruá region in Acre, so save this place. And in this study, we can also identify the highest risk group. So it's observed that the cases are more prevalent among young pregnant women aged 15 to 24 years during all the years that we studied. And the highest risk are among those, among those aged 10 to 14 years. So this further increase the risk of adverse outcomes with a combination: malaria in pregnancy, first pregnancy, and teenage pregnancy. So a real bad combination. And just of curiosity, this map is in the supplementary material, and I show that we also have autochthonous cases of malaria pregnancy in the extra Amazon region, mainly here in the Atlantic forest region. So in São Paulo, we have malaria too. So this was the first major work on the epidemiology of malaria pregnancy in Brazil, and that we consider so extremely important, especially for the health service and the malaria control programs to identify where places need more attention. So, and now we are going to a very special region, so which I will show as an important hotspot for the disease to understand malaria pregnancy in this region. So the Juruá region in Acre State, it's formed by 5 cities in gray here in the map. So Cruzeiro do Sul, the largest and main city in the region, Manso Lima, Rodrigues Alves, Porto Valter, and Marechal Thaumaturgo. And to increase the understanding of gestational and placental malaria in regions outside the Africa continent, and where vivax is more prevalent, we conducted a cohort study in this region. And why these areas, why we choose a study here? So this region is concentrated with a huge part of the country's malaria cases, approximately 22%. And of all reported cases of falciparum malaria in Brazil, approximately 45% occur in this region. So a special region to study malaria. So it's become an important malaria study site, and not only in the area of specifically malaria pregnancy, but including the genetic of the parasite, dynamic of transmission, study of vectors, among others. So we conducted a prospective follow-up study that enrolled 600 pregnant women. So the data and samples were collected at multiple time points during pregnancy. So the women were followed until delivery, and we evaluated all malaria episodes and the pregnancy outcomes. So until now, our studies were only focused on evaluating samples from the moment of delivery. So only this time point. And only recently, in the last 2 years, that we have been able to evaluate the other time points. So the next 2 works that I'm going to show you were developed using only these time points, the delivery time point. This map is just to show you the spatial distribution of all pregnant women in the study. So the women were included in the 3 cities with the highest incidence of the disease, mainly here, Cruzeiro do Sul, Mancio Lima, and Rodrigues Alves. And this is the spatial distribution of women with malaria in the central area of the Cruzeiro do Sul. So we can see that the cases are concentrated mainly around the edges considered peri-urban area. So about the material we have. So, from the placenta, we have the weight record, data on microscopic assessment. We collected fragments for histological evaluation, which use the tissue microarray technique for the analysis. We collected different types of slides to check parasitemia, and blood samples from the placenta and umbilical cord. From these samples, we used the red blood cells to verify and confirm species and parasitemia in all samples by real-time PCR, and the placental plasma samples we have used for quantification of several markers, such as angiogenic factors by ELISA and cytokines by CBA. Regarding clinical information, we evaluated the anthropometric measurements of the newborns, and we have a large database with more than 700 variables, including maternal clinical and epidemiological information, data on infections and treatments, and much more. Okay, and based on the information, specifically the delivery time point, as I said, we have these 2 papers. One that we published in 2019 with the emphasis on falciparum infections, and another that we published last year focused on vivax infection. So I'll show you the main results of each one, starting with the falciparum. So it was by making these anthropometric measurements in a systematic way that we observe something that has little description in the literature when you talk about malaria in pregnancy, which are cases of reduced head circumference and even cases of microcephaly in babies of pregnant women who had malaria. So it's known that microcephaly can occur due to many factors, as we can see in this table. The causes of microcephaly can be genetic or acquired. So, which is where we propose the classification of cases observed in gestational malaria because of placental insufficiency due to the set of all factors that I said earlier: fibrin, necrosis, inflammation. So for this manuscript, we conducted 2 cohort studies, one prospective and one retrospective, using databases, but I only talk about the prospective one, which was the follow-up of 600 pregnant women. So at the end of our exclusion process, 409 pregnant women remain for the analysis. So first, we compare the non-infected with infected pregnant women, regardless of the species of infection. So what we observe in this first graph was the pregnant women who had malaria has a baby with small heads. So can be seen from the red curve shift to the left. Then we divided by infection species and observed a greater left shift in the falciparum infections, this red two. So, and to confirm this association, we use regression models and observe that pregnant women who had falciparum infection are more likely to have a baby with a small head and even microcephaly. So then we proceed to a placental analysis to try to understand why this happened. So as for placental malaria, we saw that in the 3 groups of infection, so babies with normal head, small head, and microcephaly had past placental malaria. So more than 50% in all groups. That is, we only observed hemozoin in the tissue and in amount that we classify as mild or moderate, and also in the 3 groups. And we're analyzing histologically, although we observed an increase in the number of inflammatory cells, both total leukocytes and monocytes, we observed a significant, statistically significant difference only in the number of monocytes, especially among pregnant women who had babies with a small head or with microcephaly. We're analyzing fibrin deposits. We didn't observe any difference between the groups, but when analyzing the syncytial aggregates, we saw a significant increase, mainly in the groups of baby who had a small head and microcephaly. In addition to histological analysis, we also evaluated the profile of angiogenic factors and leptin in placental blood samples. So, important factors to better understand the health of placenta. So, in general, we observed an imbalance in all of these factors, but more markedly of angiopoietin 2, VEGF, Ty2, and leptin. So it's important to point out that this is just a picture of the moment of delivery, where most were no longer infected, as I said earlier, had past placental malaria, were treated, and even so, we still observe important change and adverse pregnancy outcomes. So although we already expected these results since falciparum infections are more severe. So we consider these results important, especially considering the context of the region and our public policies for malaria control. Okay, and what about vivax infections? So for now, for this work, we are excluding all falciparum infections, so only non-infected and vivax infections, and we are assessing the impact of the infections on the different trimesters of pregnancy. So, first, using logistic regression, we can observe that when infections occur in the first trimester, there is an increase in the odds of preterm birth, low birth weight, and a reduction in the head circumference and length. So important alterations. And analyzing the 4 anthropometric measurements of newborns, we observe a subtle reduction in median in birth weight, but a statistically significant reduction in head and chest circumference when infected, when an infection occurs in the first trimester compared to non-infected pregnant women. So, and about placenta, do we also have placental chains for vivax infections? So yes, we also observed an increase in the number of syncytial aggregates and in the infiltrate of monocytes and leukocytes. However, in vivax infections, more than 90% of women were classified as placental malaria negative. So this is interesting. Vivax infections are also associated with placental chains, but without the presence of the parasite or hemozoin in placenta tissue. Well, let's check the profile of the angiogenic factors. So, and again, similarly to falciparum infections, we also observe an imbalance in placental angiogenic factors. So in all factors that we analyze. And when divided by trimester, we lose statistical power because the n is small, but it's still interesting result. And so we thought it could be something systemic. So we ended this paper by testing the hypothesis that previous exposure to malaria could be influencing the observed adverse outcomes. And unfortunately, no. We only measure total IgG against PVMSP119 protein, which is a protein present on the surface of the merozoite, widely used as a marker of previous exposure. And although we observe a high value among pregnant women who had malaria in pregnancy and had a lifetime history of malaria, we found that these antibodies don't protect against poor pregnancy outcomes induced by vivax infections. So always a big challenge to study vivax infections. Right? Very happy. And now, what are we doing? So since last year, 2 years, we've started to study the earliest time points, that is from the first trimester, our recruitment time point. So this is the last part of my presentation, and what I'm going to show you are the latest results that we have and that I'm actually still analyzing. So this is this line of study is my postdoc project focused on the placenta, but analyzing infections that were there at the beginning of pregnancy. So this is because what we have in this picture. So the infection occurs in the first or second trimester of pregnancy. The woman receives the treatment, and even then we are also observing changes and changes in the placenta and adverse outcomes. So we believe that the malaria inflammatory process can be perpetuated by hemozoin, parasite DNA, and GPI. So what we can observe here, so increase in the number of syncytial nuclear aggregate, fibrin deposit, and in the monocytes infiltrate, even in infections that occur only in the first trimester and pregnant women being treated. So knowing this and that currently placental malaria or lesions in this tissue can only be diagnosed after the delivery, obviously, we aim to identify a set of biomarkers that can predict placental change early in pregnancy. So in the first infection, for example, using maternal peripheral blood samples. So these markers should be easy to measure so that a possible introduction into the prenatal routine in endemic regions can be considered. So we selected a panel with approximately 20 markers that are classified in these 5 groups. And we are using these 3 techniques to for quantification. So so far I've only been able to do a preliminary analysis of these 3 groups: hormones, angiogenic factors, and lipid metabolism markers. We already have the cytokine results, but I haven't had time to include them in this analysis. So, okay, first, we evaluated the levels of biomarkers by infection group. So, non-infected, vivax, falciparum, and mixed infection. So, of the 2 hormones, we observe a decrease in estradiol levels in infected pregnant women. Of the 5 angiogenic factors, we observe an increase in endoglin and VEGF levels, mainly in the falciparum and mixed groups, and decreased levels of leptin and PLGF in infected pregnant women. And finally, in the 2 apolipoproteins, we noticed a decrease in ApoA and an increase in ApoB in pregnant women who had malaria, so all groups. And to select the best molecules, those that will enter the prediction model, I'm using 2 statistical methods, so correlation and logistic regression. So then those markers that present p-values lower than 0.05 in both tests pass to the analysis of sensitivity and specificity. So these 5 until now. To test this diagnostic ability, we are using the area under the ROC curve and values from 0.7 onward. Diagnostic discrimination is already acceptable. So, analyzing by group, it's observed that only angiogenic factors and apolipoproteins present good performance for diagnostic discrimination with AUC of 0.76 and 0.74. And combining the 5 markers that we selected by statistical methods, the diagnostic performance improved, increased the AUC to 0.79. So I'm very excited with these results. I received the new data recently that continues this. Yes, for the next seminar, I have these results. Okay, well, my last slide summarizes our main observations about malaria in pregnancy in Brazil. So we observe reduction in malaria cases in pregnancy over the 15 years that we analyzed, and we identify the disease hotspots. We also saw that malaria is concentrated among younger pregnant women that agree in the literature. We showed that falciparum malaria was associated with small-headed newborns, and that Vivax malaria in the first trimester was associated with preterm birth and reduced anthropometric measurements of the newborns. And from our latest results from the set of biomarkers that we already have the results of, we are observing that several of these markers are altered in maternal peripheral blood, and so far we already have the combination of a possible set that presents a good diagnostic performance. So I really believe that new diagnostic tools are important, especially for introduction into the prenatal routine. So I'm a nurse, I love this idea. So improving the care of pregnant women in endemic regions. So I would like to thank you, my research team, Professor Claudio. None of these results would be possible without the support and collaboration of each of these incredible professionals. Thanks for the funding agencies, and thank you all so much for coming. So some images, some pictures of me and then carriers during my PhD studies. He's in Cruzeiro do Sul. So thank you.
Thank you, Jamille. So beautiful presentation, not only in terms of your results, but also your slides, your picture figures. They are really beautiful, brilliant. So we will now are open for questions. Let me see if there's any. Normally we start from the chat, but you guys also feel free to raise your hands and ask your questions. If you feel shy, you can ask your question in Portuguese as well.
Sim.
No worries.
Yes, no worries.
So, all right, so maybe I will start with something that, Julio is here. I think, Julio, are you?
Okay, congratulations. It was a very didactic presentation. So I learned a lot about your work and the system and the problems. Was very curious to know, because I don't know if it is possible, also based on ethical standards, to get the biopsies during the process, because you are very, very much interested in the first trimester.
Yeah.
When things may, go wrong or not. So it is very important that the pathogenesis at this stage is focused on the first trimester from what I got. And then we saw descriptions of the pathogenic outcome of the histology. It's not so clear to me if you are looking at an endpoint, which is by the time of birth, or whether this is reflecting the time window that you are interested. For example, fibrinoid, it's, of course, you can have fibrin formation, and then you will have degradation of fibrin during the dynamics of angiogenesis, because supposedly it is important to have plasma extravasation, coagulation, in order to have the angiogenic process moving on, right?
Yeah.
So I was just wondering if you have also measured that, assuming that you have that picture on the first trimester, whether you had the opportunity to measure and detect fibrinopeptides, dimer accumulation, thrombin activity. I mean, there is a broad range of factors that perhaps in that narrow window, are being activated, which would be ideal for you, because then you don't need biopsies, etc. You have a biomarker in the plasma. It's not clear to me if how this has been approached so far, or whether this is something that you will be able to do in the future. In an ideal setting, you would have an animal model that is, perfectly reproducing the process, which is not the case. So you don't have that option. So the only possible way to do it would be to correlate the histopathology with the presence of factors that could be involved in the pathogenic process. So I wonder how are you relating to this? Because it's very interesting that you see angiogenesis factors, but we are not necessarily seeing angiogenesis there, right? So this was not at this point object of investigation.
Yes, yeah. Pandemic, unfortunately, stopped all my lab work. So yeah, we have a big panel of markers. So this year it's possible only do these, unfortunately, the angiogenic factors. But yes, our idea is to measure many other markers to try to identify, because we want to see not only placental malaria classic, parasite or emosine, but some lesions that this parasite can be doing during the past placenta, for example, vivax, not adhere to the tissue. So yes, it's I know it's very important to investigate other markers and not only angiogenic factors.
But the coagulation could be a good bet, and I mean, if you look even to what we've seen during COVID, etc., people didn't have access to biopsies from the lungs, but they looked at peripheral blood and they look at tissue factor. So it's not impossible that during, and since it's in your plan, to analyze peripheral blood monocytes, which, they look encouraging, right?
Yes, so it's a good idea.
You could include the analysis of coagulation system, because there are two pathways. And in both pathways, you could have potential biomarkers, to follow up what's going on. We could discuss and try to give you some advice on what could be the markers that you should look at.
Oh, thank you so much. It's a great idea.
No, it's not even an idea, but it's just an attempt, to bring the discussion and to make you aware that there are some interesting possibilities based on what you have exposed. It was a very nice presentation. Thank you so much.
Thank you, Professor.
Excellent points, Julio. Jamille, just to, I think a bit in the same direction, but just to make sure that I'm not being confused here. When you classify in the disease in active, acute, and active chronic, and past, this is only, I mean, is related to the time point that you collected the samples, which is the term, you know, it's at the end of the, so as Julio was saying, so it doesn't mean that, you know, in the first, that there's no possible correlation to the first trimester.
Exactly.
All
Yeah,
right.
especially for Plasmodium vivax, for example, that not appear at the tissue, but of course, during the first trimester, during the infection, maybe circulated on the tissue and recruits inflammatory cells, and yeah, but at the end, maybe we don't see more anything.
That's right, because at the first sight, I said, well, why the past infection would lead to a more severe, you know, outcome compared to an acute, but that's probably because the mother has cure, has, you know, the disease, and the disease was happening beforehand. Is that the right thing to think about?
Yes, these mothers receive the treatment, so we don't have any parasite in peripheral blood samples, and it's not possible sometimes, especially for vivax infection, to find this parasite in placenta.
Right. Okay, that's it. And is there any, I think you show some of the data, but also I didn't, there was too many information. Is there any difference between the first infection in the first trimester or reinfections and multiple infections and the outcome as the, you know, one of your measures, you know, the brain, the cranial size and whatever?
Yes, yes. We saw that main infections during pregnancy, yes, it's the worst, especially for vivax. Yes, yes. For example, vivax treatment, pregnant women don't receive primaquine. So the only drug that can total cure for epinozoites. And so pregnant women receive only chloroquine. Because of this, during the pregnancy, we have infections each 2 months, for example. In our current, yes, each 2 months, when we have an infection that is not possible to do, so it's not possible to say if the same infection or a relapse, because you don't receive primaquine. So it's accumulation. So for vivax, for example, accumulation. If one infection, it's bad, but 2, 3, and 4, it's worst. Yes.
And also, I'm asking here, but guys, I see Gustavo. If you want to ask questions, anybody, just raise your hand so I can organize the questions.
Yeah, actually, it was something like that because as you were talking about the vivax, because as she said, like the epinozoites can remain latent for undetectable for months or years, and then maybe could appear in the moment that she is pregnant, for example. It cannot be treated during this point. And the relapse, I guess that would be, I guess, the most complicated moment to detect of the vivax. When she was presented very well, congratulations, by the way. I just was thinking about this one. And when you start to talk about it, I said, oh, wow, that would be a little bit complicated to detect specifically the moment of the relapse of the vivax. I guess that would be really complicated, but that would be a challenge to go on.
Yes, yes. I'm here at the London School Hygiene Tropical Medicine in London just to study the genetic of the parasites, to try to each of these time points, especially the parasite, the placental parasite, to check it's the same or others. But yes, for Vivax, it's too difficult because it's an endemic area, and maybe this epinozoite, it's not only it's maybe possible to before the pregnancy. So it's so hard to study Vivax in pregnancy. But yes, maybe with the genetic study that I'm doing here, it clarifies some points, but not certain. It's difficult.
And do IgG, for example, for an endemic area is gonna be like okay, most of the people is gonna have IgG against, I don't know, CSP or TRAP or something like that. This protein, this marker would be really, maybe you would have a lot of antibody in most of the people. Yes, I did a great biosensor to detect like CSP and CSP of Vivax, and that was really challenging because most of the people was detectable. Like, how can you decide? Okay, you can. It's gonna be traded or not, because as I said, the Vivax can remain for months or years, and then have a relapse exactly when the woman is pregnant. But actually, it's quite difficult. But this would be a nice goal to develop, as you said, like a new diagnosis, something point of care to be really precise in that moment. And if you have like some relapse, it could be or not relapse of Vivax. It would be a really nice challenge and a nice project, actually.
Yes, this month we have other paper at the Lancet Regional Health. It's just about the relapse on Vivax infection in pregnant women. So yes, we organize all samples, I genotype here, and it's not possible to do, okay, these are relapse, because we only investigated IgG of PVMSP190, but it's endemic regions. It's possible. Exactly. I don't know, but yeah, the results are very interesting, especially because relapse we can identify the same parasite, but it's not possible to say, okay, real relapse. No.
Yeah. Anyway, congratulations. Very nice work.
Thank you.
Jamille,
yeah.
Let me just see if also I haven't missed anything, but because of the importance of this active infection in the first trimester, are people considering treat prophylactically the pregnant, women in this endemic area? Because as I understood, I mean, if they pass the first trimester, then the complications are more mild, less severe. Is that right? So why don't we keep, or not?
Yeah, not really, especially in Brazil.
Entra, pode entrar.
We have the treatment, for example, for Vivax, only chloroquine. And after the first acute episode, these pregnant women receive chloroquine weekly until the delivery. This is the new treatment that we use here. And for falciparum infection, it's a combination of lumefantrine and so it's a combination. I don't remember. And treatment of falciparum infections, it's okay. It's we can observe a cure, but Vivax, we don't have a prophylactic treatment. So.
Yeah, but here in Brazil, mostly it's falciparum, isn't it?
No, Vivax.
Oh, it's Vivax. Oh, yeah. Okay.
Yeah, Vivax.
So to give chloroquine in the beginning before an infection has no impact.
Okay. This weekly chloroquine, maybe pregnant women don't have other episodes during pregnancy, but it's not possible to say that it's cured. Maybe it's a epinozoite after the delivery, after the 6 months. Maybe it is epinozoite deactivated, and yeah.
No, I know, but my point is that because I think the amount, so the active infection, as you mentioned, is very important in the beginning of the pregnancy. So perhaps in endemic area, as soon as the mother knows or they plan, to get pregnant, they should start getting chloroquine just to keep at least the number of parasites in check or whatever. So until they pass the most important period, which would be the 3rd month. And then I don't know if you can just keep giving, chloroquine or something during the whole pregnancy, if it also affects the newborn, the baby, whatever, the fetus.
I think it's a good point. And I know that people that are at risk of autoimmunity, pregnant women, they receive chloroquine. I mean, in every center here in Rio de Janeiro, from the beginning. From the beginning. So it seems that chloroquine at low dose, I don't know if it's in the same dose, because what Gustavo is proposing makes a lot of sense. But I don't know if the dosing, would be appropriate.
Right.
Yeah, the dose is based on the weight.
Yeah, a dose that has been approved and that patients are taking in Rio and Sao Paulo, Belo Horizonte, or whatever, would be the same, that would give a better protection during the 1st trimester to a pregnant woman was Vivax, as Gustavo suggested. Does it make sense? That, I mean, do you think it because it's logical what he's saying,
Yeah, I agree. I thought that pregnant women that receive, in our court, for example, that receive chloroquine during pregnancy, we don't observe adverse pregnancy outcomes. So it's good to use, but only after the 1st infection. So
yeah, but why is that? Why after you detect? Why you just don't say, well, these women are in the endemic area, therefore they are subjected to infection, so let's just start treating.
No, because you don't know if they are going to get pregnant, so you're going to give
no, when they plan, or if they, that's what I mean. That's because some I imagine that some just become pregnant, but most plan to become pregnant. You know what I mean? So if you get this as a, advisor, whatever, so you say, okay, so if you want to get pregnant and you are in an endemic area, so start to getting chloroquine, and then it won't do any harm to you or to your fetus, but can save later, because you may get malaria.
It's very funny because I put exactly this situation on our last paper, and the reviewers, okay, take it out. It's absolutely, and I put more. For example, it's difficult, but okay. If a woman wants to be pregnant, the planning this starts with the treatment of primaquine before, using before, make it to eliminate the epinozoites possible. And then when you start pregnancy, maybe, yes, you observe. But it's very controversial because you use medication during pregnancy. So it's not ethic. It's difficult to.
Well, it shouldn't be ethic in a place that has no malaria, no problem whatsoever. But in an endemic area, just go with the statistics and say, well, maybe it's good idea. I think you should have, fought the referee and left your.
Yes. We have now during the prenatal visits, it's obligation to do a test in all visits. So especially because in endemic areas, we have a lot of asymptomatics. So especially during pregnancy, maybe the symptomics, it's so low, maybe it's don't have symptoms. And yes, but
I think yeah, I think you should talk with rheumatologists just to find out. Yeah, seriously, you know, I know people that are pregnant and are taking chloroquine, and I was very surprised. I'm very surprised, but they are, you know, experts in rheumatology in Rio, people that I know very well, you know, taking chloroquine from the beginning. You have to discuss the dose because they feel very, very confident that there are no collateral effects. So, I mean, I think that Gustavo was a little bit too extreme, you know, too radical, because maybe you don't need, you know, to do prophylactic, but at the moment that the person is pregnant, you know, as soon as they're pregnant, you start the procedure.
Yeah, but that's what I'm saying. That's what I'm saying. So, prophylactic means before you detect infection. So you don't
before detecting infection, not before pregnancy.
No. Once you plan, you say, all right. So no, you know, that's it.
After pregnancy is confirmed, right? I agree with you.
Yeah, it's a good point to discuss with our politics.
Yeah. The doctors first, and then see, you know, and then
start studies involved this topic.
And don't mess with politics, because if you mess with politics, then you know it's over.
Okay.
Jamille, there's a bunch of people, you know, congratulating you and you know, saying great seminar. Let me just get a couple of questions here. One is from Valdirene. She asked if you look for cerebral malaria in your cohort as well.
No. It's very difficult to identify cerebral malaria in Brazil. It's possible only, it's more common in children in Africa continent, but in Brazil we have a few cases and we don't measure in our pregnant women.
All right. And then Victor also asked something about the methodology. He was wondering about the possible confounding factors when you measured the head of the newborns. Which ones did you consider in your study? The Zika virus, other kind of infection, drugs, malnutrition? What was the correlation, I think?
Yes, we test for Zika, dengue, chikungunya, torch infections, all the diseases that we have methods to check. Yes, we do this screen in all these pregnant women so we have only malaria as infection, and yes, we try to control all these variables, the treatment, other drugs, if other drugs can interfere, and yes, we excluding, and because of this, we'll lose our any and remains only 5 with microcephaly, because the number, when you look our database, we have a lot of babies with head circumference lower than the normal. But yes, we check, and in this population, this study, it's clean.
All right, thank you so much. I don't see any other questions, just more congratulations. So thank you very much. Enjoy your time in London. Come back soon.
1 year.
Yeah, all right, that's fine. 1 year goes
so
like
fast.
that.
Yeah,
and we will be looking forward to hear for updates of your beautiful work.
Sure.
Okay? Thank you so much, Jamille. All right,
Thank
and
you.
bye, everyone. Have a nice weekend, all of you. Okay, goodbye.